All right, so I think we'll get started. I'm Brian Berkey, the current president of the American Head and Neck Society, and I'd like to welcome everyone to this town hall on focus practice designation for adult complex thyroid and parathyroid surgery. The focus practice designation that we'll be discussing tonight is a new designation opportunity within the American Board of Medical Specialties. Approximately 3 to 4 years ago, the American Board of Medical Specialties reached out to the American Board of Otolaryngology Head and Neck Surgery to invite them to join in a joint focus practice designation with the American Board of Surgery concerning endocrine surgery. Brian Nussenbaum, who you'll hear from tonight, the executive director of the American Board of Head and Neck Surgery, Head and Neck Surgery in general, invited the American Head and Neck Society to participate in the focus practice designation working group for the American Board of Otolaryngology Head and Neck Surgery and have representation during the deliberations. We had active participation in those deliberations, which you'll hear many of the people who were involved. Tonight, you'll hear the fruit of those highly collaborative deliberations and the potential opportunity for ABO AHNS diplomates and American Head and Neck Society members who do complex head and neck surgery, albeit somewhat in the future. Tonight's participants, again, we're all involved in the deliberations in one way or another, and they include Brian Nussenbaum, the American Board of Otolaryngology Head and Neck Surgery Executive Director, Dave Stewart and Lisa Orlov, who do much endocrine surgery and represented both our society and the American Academy of Otolaryngology Head and Neck Surgery. Greg Randolph and Sherry Ann Nathan, again, well-known endocrine surgeries who were the American Head and Neck Society representatives in that working group. And Don Weed, the ATC chair for the American Head and Neck Society, who will kind of represent some of the opinions of the trainees. As well, you'll hear from Mike Singer and Brendan Stack, who are our endocrine section leaders, and who will help me moderate a question and answer session. Again, we'll have individual presentations and then time set aside for general Q&A. Please submit those questions for question and answer via the chat function. And if it's specifically addressed to one person in particular on the panel, please note that. Otherwise, we'll let everyone have a shot at it if they want. I'd now like to introduce Brian Nussenbaum from the American Board of Otolaryngology Head and Neck Surgery to give more foundational details. And Brian, I know you have some slides. Before that, just 2 quick messages from our sponsor. Next slide, please. First is, if you are a member or thinking about becoming a member of the American Head and Neck Society, it is the single largest organization in North America for the advancement of research and education in head and neck oncology. There are many benefits to membership, and those were listed. And please, we have a meeting scheduled for July in Montreal. That's our international meeting, and the information is listed here. We'd love to have you join us. So with no further ado, Brian Nussenbaum, if you'd like to take over.
Sure. Thanks so much, Dr. Berkey. And I also wanted to start by thanking the American Head and Neck Society for organizing this informational town hall and webinar this evening. So on this first slide, I did want to point out that the logos of both the American Board of Otolaryngology Head and Neck Surgery and the American Board of Surgery are on this slide. Dr. Beisky, the CEO of the American Board of Surgery, and I both thought that this is very emblematic of the collaborative work that both of our boards have done together over the past several years in terms of this effort to have both of our logos on this slide. I do need to add, though, that I am not a spokesperson for the American Board of Surgery, nor is anybody on the panel tonight. So I can speak on behalf of the American Board of Otolaryngology Head and Neck Surgery, but will not be speaking specifically on behalf of the American Board of Surgery. it's good to talk about terminology first. And so, and what you see on this slide is that for an individual who completes an ACGME accredited residency program and fulfills other requirements for board eligibility, that individual can go through the primary certification process. So that would be obtaining primary board certification in, say, otolaryngology, head and neck surgery, or in general surgery. Now, if an individual completes an ACGME accredited fellowship, and if the respective board offers a subspecialty certification in that sub-certification, then that individual can become eligible for and apply for and once passing the exams, the assessments, become subspecialty board certified. So in otolaryngology, head and neck surgery, examples of subspecialty certifications are neurotology, sleep medicine, which there are 6 different boards that participate in the sleep medicine subcertification, or complex pediatric otolaryngology. By definition, for a subspecialty certification, you need to complete the ACGME accredited fellowship, meaning that there are additional knowledge, skills, and abilities that you get from the fellowship that you don't get from the residency that qualify you to become sub-certified. For that reason, for subspecialty certifications, there is a training pathway, but only a practice pathway upon initial introduction of a subspecialty certification in terms of a transition period. But ultimately, that practice pathway goes away because by definition, you need to complete the additional training to be eligible and qualified for the subspecialty certification. In 2017, the American Board of Medical Specialties introduced something new, which is called Focused Practice Designation. And I'll be referring to Focused Practice Designation as FPD throughout the webinar. Now, Focused Practice Designation is not a certification. It's not a subspecialty certification. It's a designation, specifically a designation of focused practice in an area that is encompassed by the primary specialty of the primary certification. So as you can see over here, the text, this is really a designation that recognizes individuals who develop additional expertise in a specific particular area of the primary specialty, but that additional expertise can develop from additional training, such as non-ACGME accredited fellowship training, or simply based on how your practice evolves over time after residency. So obtaining the focused practice designation, since it's the area is part of the primary certification, does not require training, and thus a practice pathway in addition to a training pathway remains open. In other words, the practice pathway is not time limited like it is for subspecialty certification. So this slide, we wanted to state at the beginning that thyroid and parathyroid surgery is in the scope of practice and will remain in the scope of practice for the American Board of Otolaryngology, Head and Neck Surgery, and the American Board of Surgery diplomates that is certified in the primary specialty. We do know that there are diplomates, or diplomates meaning board certified physicians, that focus their surgical practice for patients with thyroid and parathyroid disease. Some of these individuals have completed additional fellowship training beyond residency. Some have not completed additional fellowship training beyond residency, but it's how their practice evolved after completing residency. And for these individuals, their continuing certification, or MOC, maintenance of certification activities, are not currently focused in what they really focus their practice on a daily basis. So Dr. Berkey had started describing some of the history. I'll elaborate on that a little bit here. The American Board of Surgery and the American Association for Endocrine Surgeons initiated a focused practice designation in what was originally called comprehensive endocrine surgery in 2019. Upon learning about this, the leadership from the board, from the American Head and Neck Society, and the American Academy of Otolaryngology Head and Neck Surgery met, and we decided that we wanted to request from the ABS and the AES to proceed collaboratively with this effort. At that point, the ABS and the AAES agreed to work collaboratively with us and not do this by themselves. And also, as part of that, the comprehensive endocrine surgery initial effort included adrenal, but at that point, the decision was made to really focus on just thyroid and parathyroid surgery and exclude the adrenal surgery. So a work group was formed. You can see here the membership from the American Board of Surgery, the AAES, and also from our board, the Head and Neck Society, and the Academy. As you could see, otolaryngology head and neck surgery as a specialty was very well represented in this working group. The working group met in person in August of 2019. Subsequently, the work group had many video conference meetings that ultimately led to an application being submitted and approved by ABMS in June of 2022. I do want to mention a few areas that a lot of the discussions and deliberations that we reached consensus on. One was for the American Board of Otolaryngology Head and Neck Surgery and the American Board of Surgery to be co-administrative boards. In other words, have a 50-50 responsibility and administrative responsibility in this effort moving forward. The second is the name of the focus practice designation. As you can see on the header of this slide, the name is Adult Complex Thyroid Parathyroid Surgery. I will mention that after the application was submitted at ABMS, there was a public comment period. There were a lot of very helpful public comments, and the Academy and the American Head and Neck Society both submitted public comments. In the public comments, there were significant concerns from the pediatric otolaryngologists and pediatric surgeons about this, that the intention of this focus practice is really directed towards adult care rather than pediatric care. And so from reading through the concerns and comments from those organizations, individuals, and groups, we decided to change the name and specifically add adult to the name of the focus practice designation. For focus practice designation, to obtain it, you do need to pass an assessment, just like you do for initial board certification in the primary specialty or a subspecialty. And so we did decide that the assessment to obtain it will be a written exam rather than an oral exam or a written and oral exam. We also had a lot of deliberations and discussions about eligibility requirements. We did decide in a big picture, broad type of way that a practice component would be required for eligibility. In other words, if you were on the training pathway, you would not be eligible for the focus practice designation just by completing fellowship. The practice component could be decreased by if you have completed an AAES or AHNS accredited fellowship, but it cannot be eliminated by doing the fellowship. We also came to the consensus that not only that the case logs that would be submitted the case logs would require some complexity in those cases. In other words, they really couldn't be like 40 or 50 hemithyroidectomies, that there needed to be some case complexity in your practice in order to be eligible for this focus practice, for the FPD. So let me summarize where we stand here in terms of the practice pathway and the training pathway. So, and we'll talk about the practice pathway first. And once again, important to know, the practice pathway never closes. The practice pathway always stays open. So you need to have primary board certification with the American Board of Surgery or the American Board of Otolaryngology Head and Neck Surgery and be in good standing. There is no fellowship training requirement on the practice pathway. The qualifying cases are 120 index cases over 3 consecutive years proximate to submitting the application. So on average, 40 cases a year. That doesn't mean you need 40 cases a year. If you have 50 cases one year, it could be 30 the next year potentially. But you do need to submit a 3-year case log of a minimum of 120 index cases, of which 20% of those cases, or 24, need to be complex. Now, if you submit 130 cases, it doesn't mean 20% of the 130 need to be complex. The number that need to be complex is 20% of the minimum, or in other words, 24 cases on your submitted case log. You can see here the qualifying cases at the bottom of this slide. The core cases are thyroidectomy, parathyroidectomy, or neck dissection for thyroid cancer. That could be central or lateral compartment neck dissection. In terms of the complex cases, this would include substernal goiters, any reoperative thyroid or parathyroid surgery, tracheal resection for thyroid malignancy, or any management of anaplastic or medullary thyroid carcinoma. And any management being that if you saw these patients in your office and there was no indication for surgery based on their extent of disease or other factors, that care of that individual, even though you didn't do surgery on them, would count in terms of a complex case. We are requiring documentation of that you provide multidisciplinary care in your practice, and the example of this would be documentation that you participate in and present your patients at a multidisciplinary tumor board. That's one example of what would qualify for that. And then the length of time to obtain the focus practice is within 3 years of completing the application. So once your application is approved, you have 3 years to obtain this. And if you don't in those 3 years, you would need to reapply if you want further opportunities to obtain the focus practice. Now let's look at the training pathway, and what's in green is different than what's in the practice pathway. You can see you still need to be in good standing with your primary certification. Fellowship training, you need to have successfully completed either an AAES or an AHNS accredited fellowship. The qualifying cases, as I mentioned, even if you complete a fellowship, you do need time and practice before applying. The fellowship alone does not eliminate the need to submit a case log. So, but it does decrease that from a 3-year case log to a 2-year case log. And with, once again, still an average of 40 cases a year or 80 index cases over 2 years, with a minimum of 20% of those cases, or 16 of the cases in your case log list would need to be the complex cases. And as you can see, the documentation is still required. And very importantly, the length of time to obtain the focus practice on the training pathway is you have 5 years. If you're going through the training pathway, you have 5 years to obtain the focus practice from the time of completing fellowship. Now, you might say, well, what happens if it's 6 or 7 or 8 years after completing fellowship? You still have access to it, but at that point, you'd be on the practice pathway rather than the training pathway. So for those that obtain the FPD, you will need to participate in the board's continuing certification process. For those of you who are already in the board's continuing certification process, you're already familiar with that program. For those of you who have non-time limited certificates from the American Board of Otolaryngology Head and Neck Surgery that obtained your primary certification prior to 2002, you would need to participate in continuing certification. The renewal for the focus practice designation would be every 5 years. You would need to maintain good standing with primary certification. Now, with the American Board of Head and Neck Surgery, of Otolaryngology Head and Neck Surgery, we do require annually 25 AMA PRA Category 1 CME credits. And I don't know the requirements for the American Board of Surgery, but for our board, the annual CME requirements are 25. And for the focus practice, we would have the same requirement as we do for our subspecialty certifications, meaning that a minimum of 60% of those 25 credits needs to be from that extra area beyond your primary certification. So as an example, if you're neurotology sub-certified, 60% of the 25 credits or 15 of the 25 credits need to be in otology or neurotology. And so for the focus practice, we will require 15 of the 25 CME credits a year would need to be related to thyroid and parathyroid content. Every 5 years, you would need to submit a new case log to verify you're still meeting practice requirements. Some of the details regarding that are still being developed. And in terms of the assessment every 5 years, it would be an article-based knowledge assessment, meaning that we would co-creating with the American Board of Surgery a knowledge assessment that is really based on key, critical, important, need-to-know articles related to the surgery of thyroid and parathyroid glands that would be provided to you beforehand, that you know what articles that the questions are coming from. And we really want to make sure that you're not only maintaining your knowledge base, but very importantly, staying up to date in this area of FPD. And so it's currently what we're going to be aiming for is an article-based knowledge assessment every 5 years. Now, I do want to comment here about this QCDR, a Qualified Clinical Data Registry. We do feel, both the American Board of Surgery and the American Board of Otolaryngology Head and Neck Surgery feel that a really great byproduct of this effort will be if there can be collaborative efforts for quality improvement initiatives in the management and care of the surgical care of patients with thyroid and parathyroid disease. The way we get there is for those who have the FPD to be submitting their cases to a qualified clinical data registry. This is still, as I have a bullet point here, you see that this is something that's going to be periodically revisited as a requirement, and we'll revisit it in 3 years. But currently where it's at is that this is something that would be strongly encouraged and required by the end of your first 5-year cycle. The details of this are still being worked out. So I do want to show a slide here of the steering committee moving forward with this initiative and effort. You can see here from Otolaryngology Head and Neck Surgery, Beth Cottrell, from Thomas Jefferson in Philadelphia. Mark Overholt is a private practice otolaryngologist in Knoxville, Tennessee, that focuses his practice in thyroid parathyroid surgery. Greg Randolph from the Massachusetts Eye and Ear Infirmary, and Greg is going to be one of the co-chairs of the group. Dave Stewart from the University of Cincinnati, and Rich Wong from Memorial Sloan Kettering. And you can see over here on the slide the members of the steering committee representing the American Board of Surgery, with which Herb Chen is going to be co-chairs with Greg in terms of this effort moving forward. So upcoming activities and opportunities, very soon we'll be creating an exam committee. That exam committee will be working along with the steering committee, to define the scope of knowledge, to define the scope of practice that's covered by the FPD, based on the scope of knowledge and scope of practice, to create an exam blueprint. And once we have an exam blueprint, to start creating content for the first assessment. And also creating a roadmap to the first exam, which I say here possibly might be 2025. The first exam will not be prior to 2025, but we're hoping that the first group that would obtain the FPD would hopefully be in 2025. So in summary, thyroid and parathyroid surgery remains in the scope of practice, and will remain in the scope of practice for board-certified otolaryngologists and surgeons that are board-certified by the ABS and the American Board of Otolaryngology Head and Neck Surgery. This focused practice designation is not intended for individuals who do a few thyroid operations a year. This is really intended for diplomats of our boards who have a career commitment to a surgical practice focused in patients with thyroid and parathyroid disease, as reflected by meeting these case requirements, both in terms of volume and complexity, in terms of demonstrating the acquisition of the knowledge base to pass the assessment and obtain the FPD. Those individuals to focus their continuing certification activities and efforts in thyroid parathyroid surgery. And then lastly, hopefully by contributing cases to a QCDR, being able to track your clinical outcomes, so you could personally see how you compare to others in the focus practice, but also that there could be collaborative specialty-wide quality improvement initiatives and efforts from the data that would be submitted to a QCDR. So this FPD has really has really been a very highly collaborative effort amongst 2 ABMS member boards with representational input from 3 specialty societies. As somebody who's participated in every webinar, I believe, over the last almost 4 years now, I really think this has been really a fantastic collaborative effort and with great deliberations and discussions over the past several years. And along those lines of the collaborative spirit and collaborative efforts that have already happened, there is a potential for a lot of additional collaborations, particularly amongst the specialty societies, for creating educational activities and enhancing the training of our fellows. And Brian, I'm going to stop sharing my slides now. And I could certainly, if there's anything relevant on the slides, that there's a question that I need to re-show the slides, I could certainly do that.
Well, thank you, Brian. Yeah, I appreciate that. Thank you for those great comments. I'm sure we will come back to them. There's already a question or two I can see in the chats and the Q&As. Brendan, do you want to take over the moderating for a session? We have a couple presentations yet before we get to the Q&As.
You bet. Thank you very much, Brian. So let's continue our discussion with presentations from Doctors David Stewart and Lisa Orloff. Dr. Stewart is professor and chairman of otolaryngology head and neck surgery at the University of Cincinnati. And Dr. Orloff is professor of otolaryngology head and neck surgery at Stanford University. And they are both going to be making comments as it relates to FPD and the American Academy of Otolaryngology Head and Neck Surgery. Dave and Lisa?
Thanks, Brendan. And I kind of want to defer to Lisa. I like her background with the Pacific Ocean, I assume, as opposed to my Ohio River background that I'm showing here. I will start out with saying that, you know, we obviously don't speak for AAO. We're here sort of representing that group. I was brought in partly because at the time I was the chair of the Endocrine Surgery Committee for the AAO. Lisa obviously has been very involved with the ultrasound ACS exported course there, and that's probably how we were labeled as representing the AAO. Lisa, do you want to start, or do you want me to throw some comments in? How do you want to do this?
Yeah, you know, I don't have any prepared remarks. I'm certainly prepared to answer questions as they come in. As you said, Dave, and as Brian, both Brians pointed out, this has been a collaborative effort. I think the duration of deliberation would probably speak to a lot of issues that got sorted out and discussed back and forth. And really, I would like to thank both boards, medical specialty boards, Brian and Joe Buski, for really shepherding the process and making sure that all specialists in all societies were listened to and represented, and that there was a lot of thought into things such as the quotas or numbers of cases, the, as Brian said, the inclusion or ultimately the sort of separation of pediatric work from adult and not just lumping that all in together. The opportunity for there to be public comment and to redeliberate afterwards. So I guess I would just say that this was the product of a long period of discussion, and yet, as Brian pointed out, it still has yet to be proven, and there is open-mindedness to revise the process or revisit the things such as the database or sort of data outcomes tools that are desired but may prove to be not what we imagine them to be right now. So all of those components were really carefully considered. So that would be my just upfront commentary.
Yeah, I would echo that. I think Brian and Joe deserve a lot of credit. And I think really the perspective that a lot of us on the panel have, and hopefully that those who are listening will understand, is that our opportunity here was either to be involved in this or to let it go without us being eligible to participate. So we all decided collectively that it would be much better for our specialty, both Head and Neck Society members and Academy of Otolaryngology members, Board of Otolaryngology Head and Neck Society members, to have this as an opportunity. I think from a AAO perspective, there was a sense that since it is a focused practice designation, as Brian kind of alluded to earlier, that it really shouldn't be about what you did in fellowship or whether you did a fellowship necessarily, but more what you're doing in practice now. So I think there's an opportunity for otolaryngologists that may not have done a head and neck surgery fellowship, but do a fair number of these endocrine surgical cases to be eligible for this. Not everybody, particularly those that were board certified prior to, say, 2002, may choose to do so, but we felt it important to have that as an opportunity and to not have it just rubber stamped because you did a fellowship in, you know, endocrine surgery or head and neck surgery, then you are guaranteed this designation. So I think that was one of the kind of academy comprehensive general otolaryngology perspectives that is important. I think another aspect from an academy perspective will be Regent, which is a registry that the academy has had for a few years now, but has not been widely adopted, would be an opportunity to fulfill the requirements to submit cases to a national registry. NSQIP through the American College of Surgeons, of course, would be available to those who are members of that. So it's not exclusive to that, but I think that it'll be an opportunity to utilize that registry. I think those are the main things that I would kind of express from sort of the academy perspective.
Thank you very much, David and Lisa. And please hang on because we may include you in some questions at the end of the event. So now let's move on to our next group of speakers. Gregory Randolph, who is professor of otolaryngology head and neck surgery at the Massachusetts Eye and Ear Infirmary and Harvard Medical School. And Greg, are you still going to be joined by Sherry Ann, our former president of the American Head and Neck Society, or is it just you?
Yeah, I think Sherry Ann is going to do her best to join us at some interval, so maybe we can go to her comments when she's able to join us.
Okay, well, why don't you go ahead and make your comments?
Yeah, my comments are pretty brief. I think I appreciate the opportunity here to be involved and appreciate Brian's willingness to have this information disseminated within the society with the lead of Brendan and Mike. And I really appreciate Brian Nussenbaum's leadership in this. Those comments that Dave and Lisa made are everything I would say. I would further emphasize 4 short little points. The first is my own perception of this added designation is really, it represents kind of an evolution or an option for further differentiation of some head and neck society and AAO members. It allows a further definition of a head and neck surgeon, or for that matter, a general surgeon, to further focus on thyroid and parathyroid surgery and declare that focus. And so I think it helps to provide an identity for those interested in significantly focusing on thyroid and parathyroid surgery. I do want to, so in that way, I think it's a form of differentiation. I think it's a good thing. It is also optional. There is no mandate here. I do think it provides, as Dave described, some positive opportunities for collaboration between general surgeons and otolaryngologists in the joint board administration of this designation. And so the formation of the steering committee and further work on the test and other curriculum materials will provide an opportunity for general surgery and otolaryngology to work together, which is what they should be doing. And the benefit of that work, I think, will accrue ultimately to our fellows. And then the final point is just that I think that this focus practice designation, when you think of practically how will it roll out, it may represent a credential that is perceived as value in certain surgical groups or certain hospitals, a way of recognizing surgeons that have that designation that may be judged desirable. We'll yet to see, as Lisa said, this is yet to be rolled out. The AAES is an organization that is embracing this designation, and we expect that many general surgeons will pursue this this designation, and so I think that will be, frankly, a competitive drive for also otolaryngologists to do it. I think that's a two-way street. So basically, that's everything I have to say, except that thus far we, that is AAO and the Head and Neck Society, have been really very well represented by the group that has formatted this basic focus practice designation on our side. Dave Stewart, Galen Garrett, Jeff Bumpus, Dave Isley, Lisa Orloff have really represented us well. And the leadership of Brian Nussenbaum has been inspiring. So you have been very well represented by this group that has led in the first stages of this focus practice designation. But that's everything that I have to say, and I'm interested in hearing questions and answers.
Very good, Greg. Thank you very much. And thank you especially for your leadership of the section and your leadership of a lot of like-minded head and neck endocrine focused surgeons over the years. We really appreciate you, Greg. Now we will turn the microphone over to Dr. Donald Weed. Dr. Weed is professor of otolaryngology head and neck surgery at the University of Miami, and he is very well known throughout the American Head and Neck Society for his long years of service as it relates to the ATC, or the fellowship training program that the AHNS has been running for years. Don?
Thanks very much. I will be brief as well. I know that Dr. Berkey had mentioned that I would present the opinions of the fellows. I will not do that, but I will provide some thoughts about how this impacts our fellows and our fellowships. First and foremost, just to reiterate the fact that both of our AHNS fellowship pathways, our head and neck endocrine fellowships, as well as our head and neck surgical oncology fellowships, are eligible as a means of the training pathway to shorten the certification process or for this focus practice designation. Important for all of our fellows to understand that, those who are looking to apply for fellowship and those who have matched for the coming year. I think as this process moves forward, there will be two really important benefits for our AHNS fellows. First and foremost, I do think that this will elevate the idea of the head and neck endocrine surgeon as a specialized job opportunity, either in academic departments, health systems, large practices, et cetera. And therefore, I think that will hopefully expand some of the job opportunities for our fellows moving forward. That's not going to happen overnight, but I do see that as a real possibility. The corollary to that is as these opportunities expand, I think we will also see greater attention to this in our residency training programs. That is, our residency program directors and our department chairs will be mentoring their residents about head and neck endocrine as one of the practice opportunities that they may want to pursue moving out from residency. And I do anticipate that will increase the application numbers to our really excellent head and neck endocrine fellowships that we accredit through the ATC and the AHNS. So I think that's a real benefit to our fellowship programs that are currently in good standing. With regard to the head and neck surgical oncology fellowships, again, real credit goes to our leadership who has worked for collaboratively for this designation. Credit to include that fellowship training pathway as well. And really, as I see it, I think head and neck endocrine with more of a focus on oncology and the advanced tertiary cases is just another sort of flavor of this that our fellowships do provide. But it is important for our fellows in our head and neck surgical oncology fellowships to see this happening, to focus on their endocrine training during their fellowships, and to recognize that as they differentiate themselves moving into practice, this again is just another opportunity for the head and neck surgeon to separate and or distinguish themselves if they so choose. Finally, a word to our program directors. We on the ATC consider head and neck endocrine, particularly in the head and neck surgical oncology fellowship pathway, to be a very important component of the fellowship year and the required fellowship training. So as those of you who have experienced site visits recently know, this is one of the important areas that our site visitors review. So this, I think, again, just further reinforces the importance of this, just as we want to know about Tor's experience, we want to know about other aspects of the training program. This is what makes our surgical oncology fellowships well-balanced, well-rounded producers of head and neck surgeons in North America. So I think that's all I have. I think it just elevates another opportunity for our fellows, and I'm interested to or happy to answer any questions that I can.
So Dr. Weed, thank you very much for your input. And at this point, I just want to recognize that Dr. Michael Singer, professor of otolaryngology from head and neck surgery at the Henry Ford Hospital in Detroit, Michigan, is working behind the scenes and managing the chat function so that we get the questions. So in that spirit, and with about 15 minutes left for our webinar, I want to start with some questions. And the first question I'm going to pose to Dr. Newsombaum, and then perhaps if others want to add in once Dr. Newsombaum is done, please feel free. The question is, Brian, can doctors of osteopathy apply for this designation?
It's a good question. So doctors of osteopathy can apply if they are a diplomate of the American Board of Otolaryngology, Head and Neck Surgery, or the American Board of Surgery. But if they're board certified by the respective osteopathic, surgical, or otolaryngology boards, then they would not be eligible, because this is purely something through the ABMS boards.
Gotcha. So for a quick follow-up question to that, let's say a person who was a doctor of osteopathy then pursued an AHNS fellowship and completed that successfully. Would that mitigate what you just described?
It would not. You do need to be a diplomate of the American Board of Surgery or the American Board of Otolaryngology, Head and Neck Surgery in good standing.
So if you, for whatever reason, did not do an ABMS approved residency in either surgery or otolaryngology, head and neck surgery to start with, then you would not be eligible for this program. Is that correct?
I would just say that if you did not complete an ACGME accredited residency program, they're not they're accredited. The residency programs are accredited by the ACGME.
My bad. Sorry.
No, that's okay. But I will say now that Brendan, to to just describe, to just answer a question a little bit more. The single accreditation system is now completed. All of the traditional DO or American Osteopathic Association accredited residency programs in otolaryngology head and neck surgery have made the move to ACGME or not, and that ended in 2020. So not everybody you do have to complete the entirety of residency under ACGME accreditation by, I believe it's 24. All of the trainees in those programs that used to be accredited by the Osteopathic Association that are now ACGME, I believe by 24, all of those individuals will be eligible for either certification with our board or the osteopathic board. And so it really would apply in a time-limited way to those in the recent past. And for those individuals, if they practice in an academic environment, they could become potentially certified in the primary certification first with our board through our specially qualified pathway if they work in an academic medical center. And so there still might be a pathway for those individuals, even if they didn't complete the residency training under ACGME.
Thank you for that answer. Obviously, there are some nuances to that question, and we don't want to spend our time in the weeds tonight, but thank you for mapping that out for us. And it sounds like it might affect legacy folks, but going forward, the systems are unified.
Correct.
Right. Okay, very good. Thank you so much. Our next question, and actually we may be picking on you a lot, Dr. Newsombaum, tonight, being the authority you are on board certification and the board. There's a question about, in your mind, what is the difference between a complex case and an index case? What defines the difference between those two?
So as I showed on the slide, an index case would be any case, any thyroid, parathyroid, or lymphadenectomy for those. Those would be the index cases. The complex cases are as shown on the slide, the substernal goiters, reoperative, resection of adjacent structures such as trachea, or any management of medullary anaplastic. Actually, Brendan, I would actually open it up to those who were part of the working group, Lisa, Dave, and Greg, to comment on, on how that all separated out as we had those discussions.
Please join in.
I guess I'll start by just saying that it's recognized that in some practice environments, there are surgeons who are referred the very difficult cases, and we want to, in some sense, acknowledge that that represents expertise, even if they are not the so-called classically considered high volume endocrine surgeon, because there's a lot of literature these days about volume, which is implying that volume equals expertise. And we all know that sometimes that's true and sometimes that's not true. You can do something many times over and over again and not do it in an expert way. But there are different definitions of expertise and different degrees of difficulty, I think, of cases. So those were some of the relevant aspects of the discussions of complexity, and also the fact that some surgeons are sought out for that particular expertise where they may not have the opportunity to do more of the straightforward cases. So I think we really wanted to be sure that there was, when things don't go easily or in as straightforward of a manner, there's recognition of the expertise that's involved in remedial surgery, in non-localizing parathyroid surgery, in revision neck dissection after a neck dissection that may have not been as comprehensive as it, maybe should have or could have been. Those are sort of some of the ingredients to the sort of complexity definition, I think.
Very good. Are there any other comments along those lines?
I might just add that I think the devil's in the details, obviously, and the case logs are going to have to be submitted and someone will review those. But an example that might not be considered a complex case would be a completion lobectomy after an initial hemithyroidectomy. In contrast, revision surgery for recurrent thyroid cancer in a previously operated bed would clearly be considered a complex case. So I think, you know, there will be some judgment leeway, but I think most of us understand that revision surgery in a previously operated field is more difficult, and that would certainly count. There were other things I think thrown out, you know, hereditary primary hyperparathyroidism, MEN1 might be a more complicated type situation. And, you know, as we've yet to really have people submit their case logs, we haven't worked through all these details, but I think that those are the ideas.
Very good. That's very helpful. Any other comments, or can we move on to another question? Okay, I think we've had some good discussion. Another question is, and this may come back to you again, Brian, why is the cycle for credentialing 5 years as opposed to 10 years, as is true for many other recertifications?
Yeah, so it's a good question. And so for I can't speak for other boards, but for the American Board of Otolaryngology Head and Neck Surgery, we actually, over the past 2 years, have transitioned our primary and sub-certifications from a 10-year to a 5-year cycle. So that for us, it's aligns with the other certifications that we offer, the certification programs we offer. As I mentioned, this is not a certification, it's a designation. The other part of that is that ABMS, I believe it was at the end of 21, approved new continuing certification standards that the boards need to be implementing by 2024. And in those new continuing certification standards, actually all of the ABMS boards need to be in cycles no greater than 5 years in length. So, so for those of you who are not board certified with AHNS, but perhaps a different ABMS board, if your current certification is cycles more than 5 years, it likely will be moving to 5 years at some point in the near future. I'm not a spokesperson for the American Board of Medical Specialties. I'm just describing what their new standards and requirements will be.
Sure, understood. And that certainly makes sense. So the new normal is 5 years, not 10 years, which some of us old folks are used to. Okay, another question. Again, this is sort of a housekeeping question, Brian, so you might be best suited for this. When this comes to pass, will you submit the cases and then become eligible to take the test, or will that be vice versa?
So there will be an application process that that our board and the American Board of Surgery will develop, and the application process, part of the application process will be submitting all the materials and your case log list. And after a review and approval of the application, that's when you would be notified that you are eligible for the designation and that you have up to 3 years to take and pass the exam. And we're initially I'm anticipating that the exam will be an annual exam, not twice a year offered, but likely once a year at the beginning.
Okay, very good. We have another question, which is a little bit of a variation from the DO question that I asked. And I'm not implying that all Canadians are DOs, but here's the question.
Yeah.
Any pathway for Canadians to become eligible for this?
So you would need to be primary board certified with the American Board of Otolaryngology Head and Neck Surgery or the American Board of Surgery. Yeah, that's, you know, in terms of the requirements at the ABMS, in terms of who we could confer certification and designation to, you need to be in good standing in the primary certificate with our board prior to submitting an application. Currently, our board, I know, does have a pathway to board eligibility and board certification for those who train in Canada, who currently train in Canada. We also, when we introduced that policy a few years ago, we had a window of opportunity for those who trained a longer time ago in Canada to become certified with us here in the US. That pathway has closed. But for those who are newly training in Canada, those individuals, once they become board certified in Canada, they are eligible for primary certification in the US, and they would need to do that prior to applying for the designation.
Okay, very good. We're starting to run short on time. We have one more question is, allow me to look at this quickly. Are there any comments from any of the panelists of how this may be used for credentialing at hospitals? So we're asking about the impact of FPD on hospital credentialing. And we've got about 2 minutes for that, and then Dr. Berkey is going to wrap up for us.
I'm not on any hospital credentials committees, but I have caught wind of the quotas that are listed in the FPD as being brought to privileging and credentialing committees at hospitals as a way to potentially limit the practice of endocrine surgery in individual hospitals. So I'm just reporting. I'm not involved in any of this, but I have heard mention of this at no fewer than 3 institutions across the country so far. So I do think that there is potential for that. Since I have the mic, I will also just very quickly say that I think that this whole process, perhaps it's obvious, but probably has more impact or immediate relevance to the young or early practice surgeon than the well-established surgeon who already has a very strong referral network. And I've seen in the chat some comments and concerns about the exclusion of DOs, for example, who clearly have expertise in this realm of surgery. And I think that I would just say that this was not lost on us during the discussions, but I think the impact of this really will be greatest and most felt by those who are starting out in practice and really trying to define themselves and compete for referrals and become recognized as experts. Those who are already recognized for that expertise, this should not detract from that recognition or from their referring physicians' confidence in them. So I think, again, as Greg and others mentioned early on, this is a completely voluntary pathway. It's not mandatory, and not everybody who's an expert in endocrine surgery needs to seek out this designation. But those are just my thoughts.
Thank you very much, Lisa. That's very thoughtful. Brian, we're at our time limit. Unless you had one other comment, I want to turn this over to Dr. Berkey so that he can close.
Yeah, thanks, Brendan. And very quickly, from the board's perspective, protecting the value of our primary certificate is critically important. And we will do whatever's necessary to make sure that as I mentioned at the very beginning, thyroid and parathyroid surgery is part of primary certification. And if we need to create a statement, policy, procedure, like what we need to do to help maintain that, to maintain the value of the primary certification, we will do.
And while I can't speak for the Academy, I would speak for Jim Danini, who would say that certainly the Academy would have a similar perspective on that. The goal here is not to exclude our members from doing thyroid and parathyroid surgery.
So I'd like to thank everyone who's participated this evening, all of our panelists and all the people behind the scenes. I'd really like to thank Dr. Singer for navigating the chat function for us. And Dr. Berkey, will you send us out?
Sure. Thanks, Brendan. I just also wanted to thank everybody here for number one, participating, including thank you to all the participants. I don't know how many we had in the end. I forget, I guess about 100, but maybe 300 people signed up, and I know that many people will be watching it. This is to be kept in perpetuity on our website, American Head and Neck Society website. So it'll be posted soon. So if people say, geez, I'm sorry I missed it, please just let them know that. So thank you to all the attendees and certainly to all the panelists, not just for your involvement tonight on a Wednesday night, but really for all your leadership. This is a lot of time. I think that's obvious to everybody who watched. And so thank you to that. I did just want to remind people, this was really meant to be an update to the American Head and Neck Society and members and to others who would join about a process that's ongoing. Clearly, as Dr. Newsombaum said, might not be completed until 2025 or 26, but really just in the spirit of transparency. We don't want people to think things are going on behind the scenes. And lastly, while we did this as the American Head and Neck Society to try and update our members and endocrine surgeons around the country who would be interested, this really is an ABMS program, right? That is co-sponsored by two boards, the American Board of Otolaryngology, Head and Neck Surgery, and the American Board of American Board of Surgery. And really, you know, this has to fit under the rubric of those rules. So there's certainly no intention to exclude people. I just want to remind people that we're all trying to provide great care together around the country. But anyway, thank you again, and certainly Lisa and Dave for those comments concerning that we don't want to be exclusionary. So thank you to all. Really appreciate everyone's attendance. And if you have any questions among the attendees, please don't hesitate to reach out to us. And again, this will be kept on the website if you want to review any content. So thank you very much and have a great evening.
Thank
Goodbye,
you.
everybody.
Good night.